Dear Walid. Yeah. So this is, dear colleagues, this is a real pleasure for me to be part of this seminar. And I really want to thank the organizing committee for the invitation, and especially Professor Bishari, who I had the pleasure to meet a long time ago in Saint-Etienne. So Walid, it's a pleasure for me to meet you, even if it's remotely. So I've been asked to talk about glomerulonephritis recurrence after kidney transplantations. And you will see that I will mainly focus on IgA nephropathy, because this is a kind of specialty in Saint-Etienne, France. But I will also have a few words about other type of glomerulonephritis. So first, let's start by a clinical case, a case of a 20-year-old male with no medical history, who consult for progressive edema with hypertension and no other clinical abnormalities. His serum creatinine at consultation is 320 micromole per liter, with a low albuminemia and a high range proteinuria, with, as you can see here, microscopic hematuria. And as for the ultrasound exams, there is a symmetric kidney atrophy. So the question is whether we need a kidney biopsy. And when it comes to a kidney biopsy, in this specific case, there could be two different approaches. First, we can consider that this is a chronic glomerulonephritis presentation with advanced irreversible chronic kidney disease. And in this context, kidney biopsy can be considered as futile with substantial risk of complication. But on the other hand, it might be considered very important to identify the causal glomerulonephritis in a context where kidney transplantation is likely to be proposed to the patient. And also, it may be important in a sense to inform on the risk and consequences of recurrence, and to define the best strategies, sorry for that, the best strategy to prevent and or to minimize the risk of recurrence. So when it comes to post-transplantation glomerulonephritis recurrence management, I think we can adopt a kind of common unifying framework that basically can work for every type of glomerulonephritis with different steps. The first step being to have a precise diagnosis of the disease in the native kidneys. And for that, most of the time we need to perform a kidney biopsy. The second step is to try to stratify the risk of recurrence and also the risk of losing the graft because of the recurrence of the disease. And for that, we can rely on specific risk factor and ideally to use biomarkers. The first step is to prevent the recurrence of the disease on the graft. And for that, we can rely on preconditioning regimen and to tailor the immunosuppressive strategy according to the patient characteristic and to the type of glomerulonephritis. And finally, after the kidney transplantation, if the disease recurs on the kidney, we have to think about minimizing the consequences of recurrence, of the recurrence. And for that, we have to consider what are so far the validated treatment that can be used in this specific context. So as for this patient, so the diagnosis was confirmed to be IgA nephropathy with a chronic form of IgA nephropathy, basically with a substantial proportion of fibrosis. So the patient was proposed to have a kidney transplant and has several questions. So, doctor, what is the probability of recurrence of the disease of my graft? If the disease recurs, will I lose my graft because of the recurrence? Can you predict the risk of the recurrence? And also can you treat the recurrence? So we are going to see each of these questions. So first of all, we have to keep in mind that recurrence of IgA nephropathy is not a recent story. Actually, it has been described a long time ago by Jean Berger himself in this seminal publication back to 1975. When it comes to what is the risk of post-transplant recurrence when we consider all glomerulonephritis, you can see that the relative risk is a little bit higher than 2 and can vary across the type of glomerulonephritis, IgA nephropathy showing a kind of intermediate risk of recurrence. When we look at the natural course of recurrence according to the type of glomerulonephritis, you can see that there is a specific pattern regarding IgA nephropathy, which is a rather progressive long-term pattern of recurrence as opposed to other type of glomerulonephritis. Very importantly, when we talk about IgA nephropathy recurrence after transplantation, it's very important to speak the same language. And actually, when you look at the literature, we're not using a common uniform language. Some author will talk about pathological recurrence, meaning a recurrence that is diagnosed exclusively based on the kidney biopsy, as opposed to a bioclinical recurrence, which is a combination of a recurrence that has been confirmed by the biopsy and that some biological and clinical translation. Another point to consider is the biopsy policy in the transplant center. So some transplant centers are using protocol biopsy, and of course, in this context, you will be more prone to diagnose histological recurrence of IgA nephropathy, as opposed to a transplant center that are only perform biopsy for cause. And one other situation is that you can discover IgA nephropathy recurrence totally incidentally because you are doing the biopsy for a totally different reason in the first hand. Another important aspect is the time, and the follow-up duration is very important when you consider the IgA nephropathy recurrence. IgA nephropathy recurrence is a time-dependent process and takes time to occur. And this is important to keep this notion in mind. When you look at the literature, there are many, many studies describing the prevalence of the recurrence and the risk of losing the graft because of the recurrence. When we can remind of the, if we do the kind of summary of the literature, is that the prevalence of the recurrence is 25% at 5 years, if we are considering clinical recurrence, and 25% of recurrence at 1 year, if we are basing our diagnosis on histological recurrence. In our experience in Saint-Étienne, France, you can see here that by 10 years after transplantation, more or less 1/3 of the patient will have recur. And more importantly, by 5 years after transplantation, 50% of the patients who will recur the disease will have recur during the 5 years post-transplantation. So what are the consequences of the recurrence on graft survival? So you can see here that if you compare IgA nephropathy patients that have been transplanted as opposed to control patients, so there is a significant burden of the IgA nephropathy recurrence, as you can see on the graft survival. Now, if you are focusing on IgA nephropathy patients who underwent kidney transplantations, you can see significant difference in terms of graft outcomes between patients who recur the disease as opposed to the patient who did not. In our experience in Saint-Étienne, very simple to remember figures. The overall recurrence concerned 1/3 of IgA nephropathy patients, and among those patients who recur the disease on the graft, 1/3 of them will lose the graft because of the recurrence itself. So 1/3, 1/3. So let's go back to our clinical case. So finally, a living kidney donor transplantation is proposed to the patient from his 30 years old sister. In this case, it will be HLA identical transplantations. And as for the recipients, it's a non-sensitized individual against the HLA system. So basically, it's totally reasonable to use and to consider this patient as a low-risk patient in terms of immunological risk. And this is the reason why we can adopt a low-risk immunosuppressive regimen, combining a monoclonal induction using anti-CD25 and tacrolimus MMF, and low dose of steroids with early weaning. And for example, we can consider to use steroids in this case only for the first month after transplantation. So this strategy is totally justified from an immunological standpoint, but the question is whether this strategy is justified in terms of recurrence prevention. So for that, we can go back to the literature and look at what are the risk factors that have been described in the literature regarding the risk of recurrence. So if you look at the risk factors that are associated with the recurrence of IgA nephropathy after transplantation, so clearly zero HLA mismatch transplantation has been consistently reported as being associated with a higher risk of recurrence. This is also true. This is also true for the male gender and for the age after transplantation, meaning the rapidity of the evolution of the disease in the native kidney. Now, when you look at what are the predictors that can be associated with losing the graft because of the recurrence, you can see that basically the use of steroids are a kind of protective in this context. And basically, this is all what we can see very consistently from the different studies that have been performed in this field. So a genetically related donor is clearly associated with a poorer outcome in terms of graft survival, and if we consider IgA nephropathy recurrence. So regarding the use of steroid, as I just mentioned, you can see that there are many studies suggesting that the fact to use and to maintain patient on steroids is protective for the disease, and as well as for the graft loss due to IgA nephropathy recurrence. Most importantly, we retrospectively study our patient in Saint-Étienne, and François Berthoud, a decade ago now, described that a polyclonal induction using anti-thymocyte globulin could be protective from the IgA nephropathy recurrence. So it was important to confirm this observation with a prospective trial, and this was the PIRATE study that was launched in France. It was a multi-center clinical randomized trials focusing on patients with IgA nephropathy who have been transplanted, and the type of induction was randomized according to two groups of patients. One group of patients receiving anti-thymocyte globulin, while the other were inducted by basiliximab. So the follow-up was 5 years for this study, with a protocol biopsy systematically done at 5 years to evaluate the histopathological subclinical recurrence of the disease. And the main result of this study are that we confirm in this prospective clinical trial that anti-thymocyl globulin is actually protective from the recurrence of the disease. So the type of induction does matter in terms of IgA nephropathy recurrence. So if we are once again going back to our clinical case, so probably from a recurrence perspective, you can see that the option that we choose was probably not the best, because a genetically related donor is probably not the best in terms of recurrence of the disease. The zero mismatch is also associated with a higher risk of recurrence. The induction was not using anti-thymocyl globulin, and we did not choose to use a long-term steroid. So another question is whether we do have some biomarker available that could be used to predict and to make risk of recurrence. So actually there are some biomarkers that have been described, and this was a collaborative study done by François Berthoud in Saint-Etienne with Jan Novak in Birmingham, Alabama, when we show in the Saint-Etienne cohort of IgA nephropathy patients who have been transplanted that the immunoglobulin directed against the galactose deficient IgA1 immunoglobulin was actually an independent factor associated with the risk of recurrence. So a promising biomarker, but we have to keep in mind that so far this marker is not yet commercially available yet, and future studies are needed to fully validate its clinical usefulness. 5 years after this transplantation, and once again, I'm coming back to the clinical case. So our patient developed high-range proteinuria with microscopic hematuria. The kidney biopsy confirmed an IgA nephropathy recurrence. And the question here, which treatment can we use in this specific context? So there are several therapeutic approaches that can be discussed, but we have to keep in mind that in this field, evidence is weak and basically is based from case reports, small series of patients. So basically what we are doing in practice is to consider therapeutics targeting IgA nephropathy in native kidney, and considering that those therapeutics could be used in the context of IgA nephropathy recurrence after transplantation. And I'm talking here about non-specific nephroprotective approaches, such as strict blood pressure control, strict control of albuminuria, using preferentially RAS inhibitor, more recently endothelin receptor blocker, and inhibitor of SGLT2. We can also consider in some instances, systemic corticotherapy, such as the one that has been described in a recent clinical trial, STOP-IgAN and the testing trial. And also, there is probably a room for the targeted release budesonide, Nefecon, that has been now approved by the FDA and recently approved by the European Medical Agency, but in the field of IgA nephropathy in native kidney. We don't have a go to use this drug in transplantation, but this is something that can be considered in specific cases. So to conclude, just a few words about two other glomerulonephritis. First, the focal segmental glomerulosclerosis. Just to tell you that the post-transplant recurrence concerns only primary so-called immune FSGS. And this is important to have a precise diagnosis of the disease in the native kidneys and to have some mechanistic insights of what was going on in the native kidney. And we always have to distinguish between primary FSGS as opposed to secondary FSGS. And among the group of primary FSGS, to distinguish between genetic FSGS and immune FSGS. As for the risk factor, so there are many risk factors that have been consistently described in the literature and that are strongly associated with the risk of recurrence: a younger age at end-stage renal disease, a rapid evolution toward end-stage renal disease, the level of albuminemia at diagnosis, the fact that there is no familial history in the patient, suggesting that it's not a genetic FSGS, the fact that a previous graft was lost because of the recurrence, and resistant to steroids during the management of the disease in the native kidneys. So do we have some biomarkers? The answer is no. The research of the permeability factor was not successful, and this so-called permeability factor is not yet very characterized. One time SUPAR was considered as potentially this so-called permeability factor, but this has not been confirmed. And to make a long story short, we don't have a fully validated factor in this specific technique. So what's going on regarding therapeutic approaches? So we know that for FSGS recurrence, we can use a combination of plasmapheresis, corticosteroids, IV cyclosporine, and some immunomodulatory agents in the first and the rituximabs. And when it comes to the recurrence of the disease, I think one of the most important studies in the field were the studies coming from the Necker experience that have been published now for more than 10 years ago by Cano, and which is basically the protocol that have been used for a long time in the pediatric transplantation, and that was adapted to the adult transplantation, combining a high regimen of plasmapheresis, IV cyclosporine, and steroids. And as you know, this protocol is very successful in a high proportion of the patients, and this is very important once the recurrence has occurred to have our patients responsive to the treatment, because as you can imagine, and not surprisingly, the responsive patients experience a much better outcome as compared to the non-responder patients. So what are the factors associated to the responsive treatment? So not many, but we think that rituximab in this specific setting could be useful in preventing, at least in preventing the recurrence. So one word about membranous nephropathy, just to tell you that when it comes to the natural course of recurrence after transplantation, the pattern is very unique, with a bimodal course, as you can see, a first peak of prevalence early after transplantation and a second peak of prevalence later on. In this specific setting, we do have validated biomarkers, multiple biomarkers that have been described in the native kidney membranous nephropathy, and that can be used in kidney transplantation and in first-hand the anti-PLA2R receptors antibody. So in terms of the therapeutic approaches to prevent or to treat membranous nephropathy after transplantation, so here again, we have to keep in mind that rituximab offers probably the best benefit risk balance in a native kidney disease, and for this reason could be effective in preventing at least PLA2R positive membranous nephropathy recurrence after transplantation. And clearly, in this field, we are in a context of using a preconditioning regimen. But we still we have to keep in mind that so far in transplantation, we only have limited data coming from retrospective and small size study. So future research is needed in this field. So to conclude, I would say that data on epidemiology, risk stratification, preventive approaches exist and can already be implemented in a clinical practice for the management of post-transplant glomerulonephritis recurrence. And this is true for IgA nephropathy, FSGS, and membranous nephropathy. Therapeutic approaches to minimize the detrimental consequences of the recurrence are emerging, but clearly need to be fully validated. And the knowledge is accumulated so far should help us to select the so-called at-risk patient for future interventional trials, the ultimate goal being to have some personalized management of the patient. And this is true in the field of post-transplant recurrence, as well as more generally in the field of nephrology. We have to move toward a personalized medicine. So this being said, I thank you for your attention, and I'm open to take your question. Thank you very much.
Many thanks, Professor Christophe. It's this very elegant lecture and presentation. Comme d'habitude. Some question from the board.
Walid, I cannot hear the question from the floor.
1 minute, please. Professor Sabri Gohar, one of our eminent professor, will ask a question for you, Christophe.
Professor Christophe, is there any chance to use the cyclophosphamide in cases of recurrence of focal segmental glomerulosclerosis?
So far, when it comes to recurrence after transplantation, basically what we are doing is translating what we know about native kidney disease, and we are basically translating the medication that have been validated in native kidney to the field of transplantation. And when it comes to FSGS, we don't have so much evidence that cyclophosphamide is working, as opposed to immunomodulatory therapeutics. But I can see what is your idea is. We know that FSGS is probably mediated by B cells, and the so-called permeability factor is probably something that is secreted by B cells and has to do with humoral immunity. So that's why we think that rituximab and more generally anti-CD20 drugs are susceptible to work. This is true also for MMF, and probably there is also a room for cyclophosphamide that has been used for a long time in autoimmune disease. But my feeling here is that since cyclophosphamide is not validated in the treatment of FSGS in native kidney, I will not use it in the first hand in the field of transplantation.
But it's well known that in native focal segmental glomerulosclerosis in native kidneys, usually rituximab does not give benefit if the primary methods or primary immunosuppression is not effective, particularly prednisone. Usually they do not respond in the native kidneys to rituximab, cyclophosphamide.
Actually, rituximab does not work if you cannot induce at least a partial remission of your nephrotic syndromes, because rituximab will be eliminated with the nephrotic syndrome. But if you are able to induce some kind of partial remission with steroids, you can fix the remission using rituximab. I agree, rituximab alone, when you are dealing with a patient with a fully nephrotic syndrome, does not work. But in the case of kidney transplantation, if you are dealing with FSGS patients, you can use rituximab at the very beginning, just before the transplantation. And in this case, we have several patients that have been treated like that. You can have some preventive effects of the recurrence of the disease using rituximab. Maybe we will have the same effect using cyclophosphamide, but I'm not aware of any data suggesting that, because I think the transplant community has been reluctant to use cyclophosphamide in this specific setting. But my bet is that it could work as well. But the thing here is the temporality when you use rituximab in the context of FSGS. If you use rituximab in a fully active nephrotic syndromes, you will not observe a very positive effect of the rituximab. First, you have to control your nephrotic syndromes, or to use rituximab because before the nephrotic syndromes occurs, and this is an opportunity that is offered in the case of transplantation. And you can use rituximab as a preventive treatment in this setting.
Thank you very much. Thank you, Professor.
Thank you.
Thanks, Professor Christophe, for your sharing with us today. And it was a very elegant lecture and a good discussion with you. Je suis vraiment très content d'être avec nous aujourd'hui. Comme d'habitude, très précise et très ravi. Je suis très ravi avec cette lecture. Merci beaucoup.
Ben, Walid, j'en profite pour te témoigner toute mon amitié et toute mon amitié à l'Égypte. À très bientôt.
This is a certificat pour vous. C'est un certificat pour vous, Monsieur Christophe.
Merci beaucoup. À très bientôt.